This week on the BackTable Podcast.
We all know CTO has fibrosis, has heavy calcifications, but in fact, there is another component in CTO, and that is organized thrombus. What appears to us as CTO, 100% occlusion, in most instances, in fact, it's not. When you look at pathology specimens, you see that in fact, it's less than 100%. Because there are many microvascular channels that are reorganized within the thrombus, thrombotic layers that occupy CTO. So two things happen. One, how come you are able to cross CTO with a guide wire? The only reason is that the guide wire finds the microvascular channels. Two, once you cross with a guide wire, if you bring a thrombectomy device such as the laser, it will not only affect the calcium and the fibrin, but it will also create a pilot channel within the layers of all the resistant thrombus. And that's a huge advantage for the laser.
Hello, everyone, and welcome to the BackTable Podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. First, a brief message from our sponsor.
A patient with PAD can show symptoms in a variety of ways. This presents unique challenges when choosing a treatment option that is effective in improving outcomes across a broad spectrum of arterial disease. AngioDynamics' Auryon system changes everything. Using cutting-edge laser tech that can aspirate anywhere, featuring a 355 nanometer wavelength and 25 nanosecond pulse width, the Auryon system conquers disease with science in a way no other platform does. With the most versatile laser on the market, the Auryon system is able to treat PAD, ISR, CLI, and ALI, whether it's above the knee or below the knee. Different from most lasers, the Auryon system's 3.5 photon energy allows it to spare the vessel wall while attacking lesions. This safety profile is why leading interventionalists have chosen the Auryon system to treat more than 25,000 patients over the last 2 years and deliver improved quality of limbs and lives. Visit auryon-system.com to learn more. And now back to the show.
Welcome, everyone, to the BackTable Podcast. I'm your host, Sami Seifo. I'm very honored and pleased to have Dr. Topaz with us today to talk to us about his journey through the world of medicine and his expertise in basically laser atherectomy and the evolution of laser throughout the last couple of decades. Dr. Topaz, thank you so much for coming to join us today. We're honored to have you.
Thank you for having me.
Oh, absolutely. We have 30 to 60 minutes. I think I can talk to you for hours at a time. We're going to try to cover some topics. Let's start with this. You've been through many continents, many states, many positions throughout your career. You started medicine in 1984. You're one of the unique physicians who had not only that medicine, but also the pathology. So I'm excited to hear from you, your expertise, but take us through your journey from the moment you started medicine through your roles. I know right now you're a professor of medicine at Duke University, and you were the chief of cardiology at their VA hospital. Just tell us your history, where did you start, and how did you become where you are right now?
So I'm a graduate of 3 fellowships in the United States. The first one was cardiovascular pathology with the legendary Jesse Edwards, one of the founders of the field, at the University of Minnesota. And that opened my interest in all cardiovascular pathology and clinical topics. I then did adult cardiology fellowship 3 years at the University of Miami. And then I did interventional cardiology fellowship at the Medical College of Virginia in Richmond. I then became an attending at Case Western University, moved to the University of Minnesota, and then in 1993 I returned to the Medical College of Virginia as an associate professor, and I was nominated to be the director of interventional cardiology at the VA, the McGuire VA. I served there for 17 years and reached the ranks of professor of medicine and professor of pathology. In 2010, there was an opportunity that was presented to me for promotion, and I became the chief of cardiology at the Charles George VA here in Asheville, North Carolina. And I served in that capacity for about 11 years, and I'm a professor of medicine at the Duke University School of Medicine. I retired from the VA recently, but I continue to be medical consultant, proctor of procedures in the US and abroad, and very heavily involved in academic activities such as ongoing research. And I'm also reviewer to several journals, medical journals, and participate as faculty in some of the leading conferences in the country and in the world.
That's amazing. I don't think a lot of people can say they have a very similar CV. So I'm going to take advantage of your expertise in both pathology, cardiovascular, and interventional cardiology. And I mean, that's something other thing you mentioned is actually you publish a lot of books, and some of the most famous books are the cardiovascular thrombus, laser and cardiovascular intervention, and also the debulking cardiovascular intervention, the revascularization strategy. There are really kind of interesting topics, talking about debulking and what we can do for thrombus, and maybe one of them, as mentioned, is the laser atherectomy. So just tell me, what's the idea behind this kind of academic plan to publish those kind of books, and where does this idea come from?
The first important book on laser application in cardiovascular medicine was published by George Abella from Michigan State University in 1993. It was a fantastic book. We all learned over the years for all the content of that book and the various chapters. As the years went by, it became clear to me when we reached 2010, 2012, that there is a need to write a new book that will reflect the changes and developments in laser in cardiovascular medicine. So that was the idea behind the book that came in 2015. And I have it here, and I will show the cover of the book. This is the book. I got good feedback from the book, and we continued to develop other ideas regarding the laser. One of the main point of interest was the interaction of laser with thrombus. But I was interested in all various aspects of thrombus in cardiovascular medicine. And that's how second book came, and you can see the cover, and the cover has a painting which the original painter called it emotional thrombus. Very interesting. He was impressed by the dangers of thrombus to the cardiovascular system, and therefore it's symbolized by the hand grenade, and the beautiful colors surrounding it, each represents the hope for new treatment for other aspects of thrombus in cardiovascular medicine. The issue of debulking always fascinated me because it encompasses everything that I mentioned before and more. And in 2022, with the publisher Elsevier, I came out with the book Debulking in Cardiovascular Interventions, and the second name was Between the Heart and the Rock Place. So I will show you the cover because the cover symbolizes everything, and you as interventional cardiologists will immediately recognize it. So for those who see the cover, you can see a cross-section, histologic cross-section of atherosclerotic artery with significant plaque. And inside the lumen, I embedded a photo of a bulldozer D9 removing giant blocks that symbolize the calcium and the resistant plaque that we encounter, because frequently we feel like bulldozer operators in those diseased vessels in the periphery and in the coronaries. So that was the idea behind these three books. I want to mention one thing that is important. From the first book, all royalties that are received for over the years for these books are donated. I donate them to the National Program for Homeless Veterans. Most of my career is in the VA, and I so much appreciate and respect the willingness of the patient to let me work with them, to help them, to treat them. So I think that's the right place to put all royalties from the books.
That's amazing. No, thank you so much. That's amazing, very inspirational. Thank you for all the hard work you've done over the years, and I think, of course, all this great charity work as well. So you brought two topics I think we can discuss. There's a lot of cardiac indications for laser, but now we're learning more and more about also a peripheral arterial indication. You mentioned two things, if you can talk about them separately. One is the utilization of laser in thrombus management. Can you tell us the interaction between laser and thrombus? When would you use it, both in the coronary field and the peripheral arterial field?
It's very important to know the history of laser interaction with thrombus. It did not start with me. It started with significant contributors to the field that preceded my time. The first one was Giancarlo Biamino, a world-renowned interventionalist in Germany, who published an abstract in the early 90s and reporting his performance of Excimer laser in peripheral arterial disease. And one sentence that he wrote reported 94% success rate in peripheral lesions that contained thrombus. Almost at the same time, John Beetle from Harvard University at that time came with the report of the Spectranetics Excimer laser. At the time, there were two leading companies. One was the Spectranetics and the other one was AIS. The multi-center study of Spectranetics included about 800 patients. And when they did the analysis, it came out that whenever they used the Excimer laser in an old saphenous vein graft, there was significant success. When I read their article, I thought to myself, why would it be such significant success? And the possibility was that it relates to some interaction of the laser with the thrombus. At around that time, at the University of Miami, Eduardo De Marchena and Steve Malone did the world's first laser in acute MI. And that was done with a laser called holmium YAG, which is 2.1 micron, solid-state laser. I had the privilege of being trained by Eddie De Marchena how to use the holmium laser, and he showed me the two cases that he later on published at the American Journal of Cardiology. I returned to Minnesota at that time, and one Saturday, there was a deer hunter who killed a deer and carried him on his back to the nearby road. By the time he reached his SUV, he developed acute inferior wall MI. I was on call. He was flown to the hospital, the teaching hospital of the University of Minnesota, and the cardiac cath revealed very complex plaque, about 95% in the proximal right coronary. Remember that we are talking about the time of balloon, laser, but it's just pre-stents. So I tried to open the lesion, the acute MI, with the balloon, and I couldn't. And the patient remained symptomatic and hemodynamically compromised. So I had no choice but to pull the holmium laser and try to see if it works the way the University of Miami investigators have shown. And it did. And then there was another patient, and we ended up publishing 9 patients with acute MI in whom we applied successfully the holmium YAG laser. And that reflected successful interaction of the laser light. It doesn't matter which wavelengths. The laser light favors interaction with thrombus. So let's look at the constituents of thrombus. What happens there? And that's a separate study that we did. We were very intrigued by the positive interaction of the laser with the thrombus. So we decided to do SEM examination of thrombus before and after laser was used. And what you can see when you look at the picture, you see that the thrombus is made essentially with fibrin fibers. They are crisscrossing the area, the content of the thrombus. In fact, there are two types of fibers, thick and thin. To the fibers are attached red blood cells and platelets. The laser has no interaction with the water content of thrombus, but the laser, any laser, creates acoustic shock waves. The acoustic shock waves create fibrinolysis. They literally mechanically tear the fibrin fibers. They tear better the thin ones than the thick ones. But it's interesting because the thin ones resist balloon. That's why frequently when you apply balloon in the thrombus, you don't get good yield because you have many thin fibers. The laser energy has no problem, and it creates fibrinolysis. Now, even more interesting is the interaction of laser with platelets. I had repeatedly patients at the VA in whom you had to perform PCI while the patient either had STEMI or non-STEMI with hemodynamic compromise, but the patient had bleeding from various sources at the same time. A memorable case, a patient who underwent tongue resection for tongue cancer in the OR, and there developed STEMI, anterior wall MI. When he was brought immediately to the cath lab, his mouth was bleeding heavily. We found proximal LAD lesion. I could not use even heparin. The plaque and the thrombus had to be opened, so we used successfully Excimer laser, put a stent. We could not even give the patient aspirin. He recovered. And I started to see that repeatedly, when the laser is used, there is a possibility that it interacts favorably with the platelets to the extent that you don't need to be triaged, or you can use lower dose of heparin, or in extreme cases, as I described to you, you can use it even without heparin on board. The way to prove it was to do basic research studies in which we applied the Excimer laser with various levels of energy to platelets. And what you do, you lase the platelets and then you expose them to ADP and collagen. If you remember, ADP and collagen are classic aggregators. If you add them to a milieu of platelets, the platelets will aggregate very significantly immediately. Lo and behold, when you use the laser, the platelets lose their ability to aggregate. Now move that to clinical situations, that's a huge advantage if you can stop platelet aggregation at the site of the thrombus and the plaque.
That's fascinating. The use of laser, there's a lot of indication for it. Let's stay on the topic of the thrombus. I mean, that's all this, what you mentioned now is in the coronary field. Do you think there's the same application for laser in the peripheral, for example, in the case of acute limb ischemia or, acutely occluded FEMPOP graft? Do you think the utilization of laser is as useful in the peripheral as what you described in the coronary?
So to answer that, I want to make a statement that atherosclerotic plaque and atherosclerotic thrombus don't have a sense of anatomic location. In other words, the coronary plaque is essentially the same as the peripheral arterial plaque. The coronary thrombus is essentially the same. And what we saw again in coronaries that you can immediately imply toward peripheral arterial disease, chronic limb ischemia, etc. We also found that patients, if you recall, there was a period of time in which thrombolytics was the first treatment for acute MI. But what happened was, in about 35 to 50% of the patients, sometimes more, it failed. It initially had some outcome, but then it failed within hours or within days. you had to go back to the coronaries, you would inject and see that the plaque is still there, the thrombus is still there. In those patients, frequently we use the laser. And what we found was that, in fact, contrary to what you would expect, it was very easy to use. That raised the notion, the immediate restoration of coronary or peripheral flow after application of laser in a patient who supposedly failed thrombolytics, raised the possibility that there is some interaction between the laser and TPA. So what we did basic research and exposed clots to TPA and to laser. And what we found, to our satisfaction, was that not only laser enhances the effect of TPA on the clot, but laser can rejuvenate the effect of TPA on old clot. The older a clot is, the longer hours it takes to the patient to present with acute MI to the PCI, the harder the thrombus and the less effective is TPA. However, if you use laser in this context, you're reversing the phenomenon. And the reason is, think about it, the laser energy, again, it affects, it demolishes, it destroys the fibrin fibers. So more content of the thrombus and the fibrin is amenable to the TPA in the system. The immediate clinical implication to the current PEI in peripheral arterial disease and in coronary application is that you don't have to use, in chronic limb ischemia, for example, you don't have to use 100 milligram of TPA. You can use significantly less, 10 milligram, 20 milligram, let it dwell for 5-10 minutes and activate a laser. The result will be that the laser will further enhance the effect of the TPA.
That's fascinating. So moving on from thrombus to more atherosclerotic disease, majority of the cases that laser used are at this time of the practice, in real-world practice, in the coronary. A lot of people use it in in-stent restenosis based on data. In the periphery as well, in-stent restenosis or critical limb ischemia. Talk to us about, in those kind of application, how would the laser be effective in in-stent restenosis, for example? Why would that be a first-line therapy in those cases?
Okay, so the interaction of laser in in-stent restenosis is very intriguing. First, it interacts favorably if you use the correct lasing technique and you enable absorption of the laser energy in the plaque and in the thrombus, then the vaporization will be successful and you'll restore flow. But of course, in the early days, it wasn't clear. In fact, the FDA correctly questioned the laser manufacturers, prove that in fact the laser light does not have any adverse effect on the struts of the stent. Before we approve it, we want to make sure that the irradiation of the laser does not affect, one way or another, weakens or even perforating the struts of stents. So one of the other giants of laser in cardiovascular medicine, it was the late Warren Grundfest, professor of biomedical engineering and professor of surgery at UCLA. And he conducted very intriguing tests. He took stents, peripheral stents, and applied to them two different devices. One was rotablator, and the other one was Excimer laser, 308 nanometer. And he did live, if you wish, video of the experiment, simply checking what interacts and what doesn't. So it was very interesting because anytime you apply rotablator, that is correct until today. Anytime you apply rotablator in in-stent restenosis, it can open the plaque. However, it interacts with the metal struts and you can see like a shroud, you can see a cloud of microparticles that are literally shredded from the stent when you apply a device like rotablator. On the other hand, when the laser was applied, there was absolutely no interaction between the laser light and the struts of the stents. And this advantage continues to present the laser opportunities to open critical lesions in the peripheral arteries that perhaps other devices are unable. Moreover, the laser distinguishes itself, as you could see in the Pathfinder recent study, we may talk about it later. The laser is exceptionally capable in CTOs of the coronary, CTOs in the peripheral, above the knee and below the knee. Why is that? And the main reason is that we all know CTO has fibrosis, CTO has heavy calcifications, but in fact, and it had been proven time and again, there is another component in CTO, and that is organized thrombus. And the interesting part of information in that regard is that what appears to us as CTO, 100% occlusion, in most instances, in fact, it's not. When you look at pathology specimens, you see that in fact it's less than 100% because there are many microvascular channels that are reorganized within the thrombus, the thrombotic layers that occupy CTO. So two things happen. One, how come you are able to cross CTO with a guide wire? The only reason is that the guide wire finds the microvascular channels. Two, once you cross with a guide wire, if you bring a thrombectomy device such as the laser, it will not only affect the calcium and the fibrin, but it will also create what we call a pilot channel within the layers of old resistant thrombus. And that's a huge advantage for the laser.
Now, with the adaptation of utilization of IVUS, both in the coronary and in the peripheral, which is still, even in the United States, the IVUS usage, both in coronary and peripheral, is still very low. But I think doing so, we are learning throughout the day-to-day practice that what we expect to be just calcified plaque or atherosclerotic disease, there are some other component to it. So we see that more clearly in the peripheral just because it's a larger vessel. So you'll be able to assess that. Commonly we see cases, and I agree with you, I think the utilization of laser would be very beneficial in this case. But if we talk about the laser indication in the peripheral, other indication also heavily calcified vessels. So our audience will ask, so should I open laser on every single case? How can you guys guide me to utilize the laser? What lesion should I consider the laser as first therapy or complementary therapy? So in your practice, or what would you recommend for the peripheral arterial? Let's talk about peripheral arterial disease specifically and your knowledge about the laser and the laser technology. When would you use laser? If someone asks you this simple question, one, first of all, should I have laser in my lab? Number two, what are the cases that I absolutely should use laser as a first therapy instead of other atherectomy devices like Diamondback, Hog, CSI, Diamondback CSI, or Roto, or other devices. So can you guide us towards how do you think about those cases, case by case?
So first of all, you mentioned the list of very beneficial tools that have very respectful position in revascularization in peripheral arterial disease. I want to expand your question slightly and mention we all the time example in the conference that you and I recently participated, New Cardiovascular Horizons, there's such emphasis on peripheral arterial disease, essentially from the iliac down. But let's not forget that peripheral arterial disease is also affecting, example, the renal arteries, the subclavian arteries, and other vessels. So my answer will cover all locations. I think one should have the laser because until today, There is no other device in the armamentarium of interventional cardiologists that can be used successfully, especially in the thrombotic components of atherosclerotic plaques, whether the thrombus is old or whether the thrombus is fresh. Laser is the only device available in which the presence of thrombus is not a predictor of complication or risk, but rather a predictor of success. It's very unusual and beneficial place for the laser in the cath lab. Any other of the good devices that you have just mentioned, the presence of thrombus frequently will lead to no utilization of the device or need to add large volume of 2B3A and other suppressors of thrombotic function. The laser also does not distinguish between old or new, fresh thrombus. The laser in your lab, whether you use it in coronary or peripheral arterial diseases, commonly does not cause distal embolization because of the excellent interaction at the spot with the plaque and the thrombus. The other devices that you mentioned frequently cause distal embolization, not because they are not good, but because of certain mechanical limitations and lack of interaction with the thrombus. So I think one should laser in the cath lab. It's important to know how to use. The laser, in my opinion, is the most sophisticated, most user-friendly for the operators, providing that you understand the physics of laser interaction with plaque and thrombus, that you understand the technique of lasing, you use the correct technique, and we can talk about it separately, and that you are building an experience and not use it. It's not a panacea. It will not create miracles. It has very predicted, solid performance. When you use the laser and understand the laser, you know what the laser will provide you in a given procedure, in given anatomy. I mentioned anatomy. I think one should have, the target should always be complex plaques. Simple plaques, plaques that you can use with less expensive devices, don't use the laser. But the laser will be useful. The more complex the anatomy, the higher the yield and the room for laser in the cath lab for coronaries and peripherals alike.
So, Dr. Topaz, I'm going to take advantage of what you just mentioned regarding the appropriate technique of utilizing laser. A lot of our audience are physicians who utilize different atherectomy devices. A lot of people don't want to use the laser because they really don't know what the appropriate use, and they're worried about complication, or maybe they're using it in the wrong setting. Personally, in the Excimer laser, I use a distal embolic protection device 100% of the time. And the Auryon laser, which is a laser we started using recently, I don't use a distal embolic protection device. Tell us, from your expertise, you're the expert, tell us what's the right way for our audience if they want to adopt laser. What's the right way of utilizing laser? And what's the right way of avoiding complication, if there's any?
So it's an excellent question because it brings you back to the mid-80s, late 80s, early 90s, when the laser was felt by some authorities that it will be so successful that it will replace the need for bypass surgery, which was, of course, exaggerated, incorrect assumption. But that's how laser was pushed. It was reflected by the technique that was used at that time. The word laser, light amplification by stimulated emission of radiation, and the laser concept always fascinated people. And laser light, and you feel there is energy. So what people used to do, they used to push the laser catheter through the lesion as fast as they could, which was a major mistake. Then the choice of the size of the laser catheter, they didn't understand that laser is not a balloon, it's not an expandable device. So when you choose a laser catheter, you should not first compare it to the size of the artery. In other words, large coronary artery, if there is 99% stenosis, take a large catheter. Wrong. You should take the smallest catheter. So complications, indeed, like you mentioned, were abound. What I remember as a fellow seeing dissections, perforations, an acute closure, which is a very interesting phenomenon with laser. George Abella, again, from Michigan State University, who is a giant in cardiovascular laser. He is the one who termed that phenomenon of acute closure from laser millefeuille, which means in French 1,000 leaves. He compared it to a French pastry that you put in the oven, and with the heat, it puffs up, and then it's ready to be served. But in the coronaries, if you use the laser the old way, the heat that is generated and the power of too fast movement across the plaque creates such acoustic shock waves that you get multi-layer dissections. The heat puffs them up and they acutely close the vessel. As a new attending in the field in the early 90s, I noticed that phenomenon, and it was very difficult clinically to use the laser because of the frequent complications. And then it occurred to me that if complications occur so frequently, maybe they have a common denominator. So I did a thorough literature search in the basic research of laser physics, and lo and behold, found that a European group of investigators found that the acoustic shock waves from the laser propagate and create the gas bubble that is the manifestation of the vaporization, the successful vaporization of atherosclerotic plaque, forms a gas bubble. The gas bubble contains huge pressure inside, in the hundreds of PSIs, if not more. And that is the reason that at that time so many dissection perforations occurred. When I realized that, I decided to totally change the lasing technique. And this is what we did. One, the more stenotic the target lesion, the smaller the laser catheter that you need to start with. The other thing is, instead of the rushing through, pushing fast the laser because it's laser light, do the opposite. Go slowly. And we did basic research examinations of laser interaction with plaque and found that 0.2 millimeter per second up to 0.5 millimeter per second. That slow rate is the rate that will enable the laser light to be absorbed properly in the plaque. If you exceed that, you're just dottering and you're creating reflection and just distribution of the laser light that has no effect. So that technique, the new technique, I published in 1993, and then we were able to show in a series of, I think, 110 patients, no perforations, no dissections, no thrombosis, no acute closure, and maybe one case of distal embolization, just using the proper matching of laser to vessel and the proper slowness of propagation of the laser catheter. And you as an interventionalist, I can tell you give you a very good example for the technique. How do you progress slowly? And the way you do it is you open a little bit the TUI, so the laser catheter has free movement. You hold with the right hand the guide wire, and the left hand you just loosely hold on the laser catheter. You don't push the laser catheter forward at all. All you do when you activate the laser, you're pulling back gently on the wire. That translates into a gentle forward slow movement of the laser catheter. And it's fascinating to see, because if you use the correct lasing technique, few things happen. One, You don't need to use distal protection device, which makes the procedure easier. 2, you're creating what we call pilot channel or pilot tunnel. And that is a very unique angiographic and ultrasound phenomenon unique to laser. The smoothness of the tunnel that is created once laser crosses successfully the entire length of the lesion is unique in the sense that no other device gives you such smooth debulking channel. What does the smoothness do? It enables, first of all, it facilitates delivery of balloon or stent, makes it easier to deploy them, and especially in peripheral arterial interventions, you don't have to inflate the balloon to nominal pressure. Let's say you have a peripheral balloon and the nominal pressure is usually 6 to 8 atmosphere. Believe it or not, half an atmosphere, 1 atmosphere is enough to enable the balloon to inflate properly so you don't get any adverse balloon-induced impact on the plaque and on the vessel. And that's unique to laser.
Fascinating. There's a lot of fear of using laser, I think, just because the laser is not understood well. I think the laser, you mentioned 2 things. The way the laser work is not just the acoustic waves, which can be used for disrupting fibers and calcium, but also the heat and the light. So it's a 3 different part of the laser. Mentioning that, can you talk to us about the difference between the traditional Excimer laser and the new kid in the block, the Auryon laser, and what's the difference between the 2, and is there a difference between using this versus the other?
Both of them are in the ultraviolet region. The Excimer laser, the 308, is based on gas, xenon chloride. The Auryon laser, the 355, is based on a very genuine idea with a patent whereby they take a solid-state laser, neodymium YAG, which is 1065 nanometer wavelengths. That laser, the neodymium YAG, had been used in the 80s and early 90s, again by George Abella and others. It was a good, solid, reliable source of laser. The problem was that it was too weak. By the time it got to the edge of the laser catheter through the optic fibers, the energy produced was not enough. Several years ago, a patent was issued, very genuine concept, which is called third harmonic. Take 1065, divide it by 3, and you get 355 nanometer, which is the wavelengths of the new laser. Why is it unique? Because the neodymium YAG is the source, but what comes out at the edge of the catheter is now very reliable, short wave, and very effective level of laser energy that interacts favorably with calcium, better than the interaction of Excimer laser 308, which, as I mentioned, is a gaseous laser. Now, there are other advantages as a result. The 355 nanometer does not have any interaction with the contrast, the media that you inject when you do angiograms, peripheral and coronary during interventions. The Excimer laser 308 has a very adverse effect of potentiation by the acoustic shock wave. The contrast absorbs the 308, the Excimer laser, and then potentiates the acoustic shock waves to a degree that causes damage. This was recognized many years ago. So the traditional technique, when you use Excimer laser, you inject the dye, you see where the lesion is, you decide to intervene with the laser. You have to use saline flush. You have to wash out any component of the contrast before you activate the laser. Then, if you want to see how much you lased, you cannot use contrast as you do the laser debulking with Excimer laser. You have to finish the debulking, pull the laser back, then introduce contrast and see whether you got good results or you need to continue. Then you again have to flush cell line and reactivate the Excimer laser. That does not happen with the new laser, with the 355. You can lase while you inject contrast. As a result, one, the overall volume that you use in 355 is less than what you would need to use in the 308 Excimer laser. Two, you use less fluoroscopy. That has a benefit for the patient and the operator alike. It seems that the interaction of the 355 with calcium, with the arc of calcium, is improved with the 355 nanometer laser. That had been shown recently by John Rodbeck and his colleagues, who presented the basic research study of the effect of the 355 on calcium using micro-CT method in order to assess the interaction between the 355 laser energy and the calcium, and they found that the 355 is very effective in creating fractures in the arc of the calcium. That, of course, leads to less resistance of the calcium as a constrictor on the application of, say, balloon and stent. And that also was associated, as was shown in the clinical Pathfinder study, with exceptionally low rate of distal embolization because the 355 energy is absorbed so successfully in the atherosclerotic milieu, especially in the calcium. I want to emphasize that we are not going to throw under the bus the excellent Excimer laser, the 308. I wrote an editorial recently in which I called it what it is, the great plaque modifier. The 355 appears to me that it provides also great plaque modification of the morphology with certain advantages that include the ability to lase while you use contrast and the reduction of the amount of contrast and fluoroscopy.
Definitely. I think that's all good point, and I think you just want to add also, I want to go back to talk about some of the recent research publication, but with the Auryon laser, you also have the ability, it's the only laser atherectomy device with a 200 centimeter shaft. So for a lot of operators who does radial to peripheral, it is very advantageous. So let's go back to the research. You mentioned the Pathfinders. I believe that you're very familiar with some of the work Dr. Shamas has been doing of below-the-knee disease. So Pathfinder will be infrainguinal, SFA, popliteal, and the other trials are just recently published at AJC regarding below the knee. Can you give us basically a summary of the finding of those research trials?
Regarding the specific question that you asked, Nick Shamas, who is an outstanding interventional cardiologist, his landmark work with the 355 nanometer appears in a special chapter in my debulking book. We need to give him credit for doing that and all the multi-center studies that he conducts. The Pathfinder recent publication in CCI, and I have to tell you that I was one of the reviewers on that paper, with Tony Das from Houston, who is a world-class interventionalist who has huge experience in applications of lasers. And the study included what we call real-world lesions below the knee. And it included, as you know, instant restenosis, calcified vessels. It included tibial lesions. It included CTOs. And they were able to recruit 102 patients with 122 lesions. And they set primary goals and they set secondary goals. And about 70% of the lesions, they achieved technical success, which was defined as laser debulking plus adjunct balloon or stent that brings the final result to less than 30% stenosis. But those are very sick patients. So 70% in this milieu is an acceptable initial experience with the 355 nanometer. Again, they had only one distal embolization out of the 102 patients, which is impressive. No cases of need for amputation, no cases for need for emergency peripheral bypass, no perforations. And the dissections that they saw were not from the laser, they were from the adjunct balloon. And therefore, there was one or two cases in which they had to do stent bail out to the dissection as caused by the adjunct balloon. Again, one questions what pressure those balloons were applied. I suggest again that in cases in which the laser, the 355, debulks first, one does not need to use the nominal pressure, use much lower pressure, and probably you will see many less dissections. But their study stands out because it's real life. They did not apply choice of select lesions that will ensure fantastic rate of success, but rather they wanted to deal with what you really see in the lab when you deal with difficult, complex peripheral arterial disease. They showed improvement of walking impairment questionnaire, significant improvement of the ABI and Rutherford class. And the interesting thing is that when they followed the patients 6 and 12 months, the benefits essentially remained. The patency remained very significant. And we are waiting to hear the results, the outcome of their 24 months follow-up. But certainly it's a study that adds to the evidence that is already known. You know, the first applications in Europe were in Poland, where they did 50 cases of peripheral arterial disease that included the iliac, femoral, and below the knee, and also with significant success because the Polish investigators were very meticulous about the technique that they used the laser. They were all vascular surgeons, and they had no laser experience before, but they understood very well the concept of laser debulking. So their success, which we hope will be published soon in the literature, their success, I think, is a testimony to the reliability of the 355. Again, providing that the operator understands that there is physics involved in the interaction of laser energy with plaque. If you accept that and you tailor your lasing technique, you can get very good results in various lesions.
Yeah, definitely. And I think just echo what you said. It's all about the appropriate technique. So slow and steady, use the right size of laser, and the different length, different anatomy, different location may require, based on the size of the vessel and the severity of the disease, may require different size of laser. So it's appropriate and important for physician to practice that. And I think Dr. Shamas's paper that was recently published at AGC also kind of highlighted a very similar result below the knee. I think it was 60 patients, and the outcome was absolutely amazing and with a very low risk of complication. So it's good to have, different application. We talked about the thrombus burden in those chronic disease, and especially for end-stage restenosis. And some physicians recently have been using, including myself, tried different technique of using a mechanical thrombectomy and the stent because we believe that there is some chronic clot there and with a good success. With the Auryon laser, the 2.0, they have a combination atherectomy, thrombectomy kind of a technique with a continuous suction plus the laser. Do you think that's a technique that will be useful? Have you seen successful cases? Is that something you recommend, or does it really matter to use that 2.0 versus, a smaller one?
Remember that the 2.0 and the 2.35 available from the Auryon company for the 355 nanometer have, as you mentioned, aspiration. The aspiration capability, while you debulk forward, you're able to aspirate backwards. It's a huge advantage. Give you an example. I was recently in Italy participating in coronary and peripheral cases, and one peripheral cases presented a chain of, I would say, 10 to 15 plaques, one after the other, and most of them very severe. There was no angiographic evidence of thrombus. The question was, if you want to use laser in that chain of plaques, which is a predictor of failure. We know it very well in peripheral arterial disease. It's one thing to deal with one plaque, maybe with tandem plaques. When you get to 5, 10 in a row, that creates big challenge and reduces the success. So the notion was, let's use a 2.0 with aspiration capability. When the interventional radiologist asked me, why do I want aspiration? I said for plaque aspiration, but I have no doubt that there is thrombus there. And his point was, well, we don't see angiographically any evidence of thrombus. My point was, whether we see or not angiographically, there is underlying thrombus there, and we better take care of it. So he used the laser accordingly and used it with exceptionally good technique, the one I mentioned to you, whereby you essentially don't push the catheter, but you pull back gently on the guide wire, and then the catheter moves forward. He did it very patiently, antegrade, and then the suggestion was that he will do it also retrograde, which he did, all the while using the aspiration concomitantly to the debulking. And as he was reaching, I would say, halfway along those 10, 15 lesions, the copious amount of thrombus that came into the container was impressive. You could see chunks of old and fresh thrombus. When he was done with the debulking aspiration, of course, we took a picture. And lo and behold, the results were so impressive because the lumen was totally open. There was essentially no residual stenosis. There was no residual thrombus. There was complete antegrade flow. And in fact, the question arose immediately, do you stent this? You probably don't have even to stent this. So the way the company embedded aspiration with debulking is a huge advantage to the 355.
Yeah, I know that's important. Just for the audience, there are two different lengths of the Auryon laser. You have the traditional length and you have the XL, which is for the radial. For the radial option, you only have the 0.9 and the 1.5. You don't have the capability of the aspiration. So if you are thinking you need an aspiration for restenosis, so you have to use the 2.0 or 2.3, which is has to be a femoral access. So, I mean, we can talk all day long, Dr. Topaz. It's an honor to talk to you. You've mentioned a colleague and good friend of mine, Dr. Das, actually works with us in our hospital at the Heart Hospital Baylor Plano in Dallas, actually. We're honored to have him. He's a great operator and a great scientist. And always great to talk to you and pick your brain on all these topics. Any final thoughts about laser atherectomy, the future? What's the future hold to this, field? I mean, you've been pioneer of this field for the last few decades. Guide us towards the future. What do you think is going to happen in the next, let's say, 5 years to 10 years in this field?
The hope is to get in the future, after conduction of proper study, FDA approval for the 355 for coronary utilization. regarding peripherals. As we have already shown with the Excimer laser, you can use it for critical renal artery stenosis, severe renal artery stenosis with complex plaques that need PEI and stenting. Those will benefit from the 355 nanometer. Subclavian artery stenosis is another fascinating area where we had used the laser, the Excimer laser in this case, very successfully. It's very reliable technology. The future, I think, is if I could show you a video how the laser energy in the bubble, the acoustic shock waves in the bubble propagate in a cross section, you would see a pear-shaped formation that propagates along the vessel. It has a certain dimension, it has a certain shape, and it continues. The dream that I have is to use it for acute stroke. Which acute stroke? The thrombotic ones. And the idea is that since the acoustic shock waves with their unique pear shape, like the fruit pear propagation, if you could harvest that and use it, you will be able to send these acoustic shock waves into carotid artery system and beyond. You won't need to bring the laser catheter itself to the thrombotic occlusion, but you will be able to send the energy to reach there and perform thrombolysis. This, I think, will be a beautiful development. Another thing, just allow me to mention, of course, is the use of, which will expand tremendously, of laser in venous thrombosis, in DVT, in other situations whereby thrombus occludes the venous system. We had used it already in patients with superior vena cava syndrome, to give you as example. We also had used the laser in congenital heart disease on a 3-month-old baby who was born with pulmonic atresia and was dying because of excessive right ventricular pressure, while the left ventricular pressure was very low, and she was essentially dying. She was blue and dying, and we were able to get into the athletic valve in the pulmonary artery, use the Excimer laser, create a channel, use peripheral balloon afterwards, and enable restoration of flow in the congenitally atretic pulmonic valve. She survived, and it's several years since then, and she's doing well. Protected and unprotected left main patients, especially in the VA population, there are instances of drug abuse, especially with cocaine. And cocaine is a huge atherosclerotic promoter and at the same time severe vasospasm. We had patients who had bypass surgery for left main, and the bypass grafts, all of them occluded within 2-3 weeks because the patient continued to use cocaine. So we had to go back and open the original critical left main stenosis. And the only device you can use in that situation is really laser and then stent. So that's where I see the future. There is a lot more to study about the interaction of the 355 and the 308 with the basic components of plaques and thrombi in the venous system, in the coronary system. So I think the future is really exciting.
Definitely. I think we met recently at NCBH at New Orleans, and I think during the PE session and DVT session, and if you notice, there's a lot of excitement about this field, but even with the DVT, the chronic DVT, we really have limited options, and people have used off-label use for the laser in those certain cases, or a stent occlusion in the venous, but that field is growing so fast, so more studies for that. It's really going to shed the light for us, and of course, an expertise like yourself to guide us through it. Also, AV fistula maybe in the future. I know people have used this in certain AV fistula. So I want to finish by appreciate your time on a Saturday. And looking forward to the future to meet you in person again, or maybe have you back on the podcast.
Yes.
And for our audience, thank you for joining us today, and looking forward to the future.
Thank you for being such a kind host, and I look forward to our interaction in the future.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dong,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang, Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.